All right, welcome. As we get ready for the last few days of this semester, let's get right on this cancer lecture, class RN26. Um, and without further ado, let's jump right in. This, what I would like to say before I get to this slide and this point here, is this is a very basic introductory. Cancer and oncology as a specialty within nursing is a very vast field. There are certifications that a lot of nurses, especially if you work on a floor and do end up giving a lot of chemotherapy drugs, that I would highly recommend if that is your area of interest. To look into, because it's great to keep your certifications if you do use them on the floor. They're very important because they give you the knowledge that will keep you and your patients safe as well, especially when using chemotherapy and other medications. So again, this is mostly an introductory lecture. How do we define and classify a tumor, the TNM? So learning how the classification system goes, and a few other things that I'll let you know as we go through. But it is a very introductory approach to what cancer is. I'd like to start off by asking this question: what is cancer according to the National Cancer Institute? And the National Cancer Institute says, yes, it's a collection of diseases. Its cells grow uncontrollably. The big question is what leads those cells to grow uncontrollably, right? When they do, they invade tissues. They end up they continue to grow, and they metastasize, which means they go from in situ, which is a word that you'll end up having to understand and know. In situ is Latin for in place, meaning it hasn't grown yet. Metastasis is it's no longer in situ, it's now spreading. And so the National Cancer Institute declares cancer is a nuclear genetic disease. So their opinion is that the reason cells grow uncontrollably, invade tissue, and metastasize is because of genetic disease. It's all in the genes. It's absolutely all in the genes. And yet we do know that there's the field of epigenetics, which says that things you do in your life, even if you do have the positive genes in your family history or your personal history, that if you do the proper things, you can turn some of the oncogenes off and make sure that the phenotype or the disease is not expressed. And that is possible through epigenetics. So the view seems to be that we're slowly sliding into understanding that it's much more complex, and that yes, genetics may play a role, but it is believed by many that the role that genetics plays may not be as important as, for example, epigenetics and what we do in our day-to-day lives and the decisions we make and what we put in our mouth and what we're exposed to. And that said, in the class that we spoke about genetics, remember what one of the individuals I mentioned and quoted, what basically it is believed that zip code affects human beings and disease, especially the poor and underserved communities, more than the genetics. And I kind of presented that in the genetics talk that we had, precisely because it goes to show you that if you don't eat the proper things, if you live in neighborhoods where all you have is liquor stores and so on, then the likelihood of developing disease, including cancer, for example, is a lot higher because you're not going to be exposed to good food and have access to vegetables. And so clearly that's an issue. So, but that said, back to cancer, from their perspective, cancer still is a nuclear genetic. So at the end, I have some food for thought about this, and we'll go over it. And as healthcare professionals, we'll exercise some of our own thinking to see what we think really cancer could and should be, and how we should approach our thought process is what I should say. Okay, that said, one of the key things to start off with in terms of understanding cancer is to be able to automatically, and this you do need to know, and you need to know the terms benign, you need to know the terms malignant and neoplasms, right? And so neoplasms just in and of itself doesn't mean anything. If you hear a doctor say or a patient say, oh, the doctor said I have a neoplasm. Well, the big question should be, what adjective are we using to describe that neoplasm? Is it a benign neoplasm or is it a malignant neoplasm, right? or tumor. And so obviously malignant tumors have more capacity to spread, to invade, and metastasize. And that is the major difference between benign and malignant neoplasms. So again, neoplasm is not a negative word. It just means that some growth is happening. Maybe there is a tumor there, but not all tumors are malignant. They could be benign. Okay, so keep that in mind. And in general, when you think of benign neoplasms, though, they're well differentiated versus the malignant neoplasms can be well differentiated, but they can also be of a wide range between differentiated and undifferentiated. And you can see and in table 15.3 in your book, you can see some of the descriptions and differences between benign and malignant. I would highly recommend you look at that in your textbook. So right after understanding what benign and malignant is and how we differentiate one from another, it's important to understand how we classify cancer. And the reason we classify cancer, why do we want to classify cancer, is what I should be asking. And ultimately, it's to sort of, you could say, stratify risk, to determine what the patient, where the patient is at, and what the proper treatment or approach to deal with the cancer we're going to take, right? So we want to be able to stratify that risk: high, low, medium, moderate. And so in order to do that, we create different systems of classifying cancer. And you'll see that we classify cancer by anatomic site. Is it lung cancer? Is it gallbladder? I mean, pancreatic cancer? Is it liver cancer? Is it brain tumors, right? We grade it, we can classify it by histology. That's where you look in through very closely to the tissue, and we'll get into that shortly. And then we can look at the extent of the spread of the disease, if any at all, and we'll do that by staging. And so you should be familiar with these three forms of classification of cancer. The classification systems, again, provide a standardized way to do a few things. One is to relay the importance or communicate the status of the cancer to us, the doctor, the nurses, the support, the respiratory therapists, and speech therapy, and so we can have a common language to be able to communicate amongst each other. Where are we in term, or where is the patient in terms of their disease, their cancer? So that's one thing, one reason why we standardize it. Another one is because it helps us to determine the most effective treatment plan, like I said on the previous slide. So by classifying it, we'll be able to be better determine how we are going to intervene. And then another one is to then be able to evaluate the treatment plan, because if we're able to classify it, we provide a treatment, then we can see if when we go back and reclassify, has it improved or is it getting worse? So we can use it for evaluation purposes. It can be used to predict and determine prognosis, how serious, how severe it is, likelihood of death and when, and should they be in hospice and palliative care, so on and so forth. And then ultimately we used classifications to compare for statistical purposes, to compare one group with another. So did all the people with lung cancer do better than with this treatment? Then so if we didn't classify cancer, it would be very difficult to be able to do any scientific research upon it. So classification is very important. In the anatomic classification of tumors and cancer, we identify the tumor by the tissue of origin, so by the anatomic site. So that's anatomy, by where it's located, and also sometimes even by the behavior. The behavior could be malignant or benign, so on and so forth. And so it's important, for example, if you have skin or a gland type cancer, then we look at the carcinomas are originating from the embryonal ectoderm versus the endoderm, which might be more of the mucous membranes, respiratory tract, GI or GU tract. So anatomically is one way that we classify it. Sarcomas, for example, come more from the mesoderm, and those are connective muscle, bone, and fat, right? And the lymphomas or leukemias are from the hematopoietic system. And each one of these, there's a tremendous amount of information. We're not going to go into these details at this point. Let me go back to the previous slide really quick. Carcinomas. With the ectoderm, you do want to remember that it's the skin and glands, and with the endoderm, you want to remember that it's usually it can affect the respiratory tract, but it's also the gastrointestinal and the GU, the genitourinary tracts, are going to be more affected with the endoderm. Whoops. So here we go. That's the carcinomas. So the carcinomas are broken down into ectoderm and endoderm. Ectoderm, skin and glands. Endoderm, respiratory, GI, GU. Sorry about that. And then sarcomas, as opposed to lymphomas, are going to be the mesoderm, and those are more tumors, cancers of connective tissue, muscle, bone, and fat. And then lymphomas and leukemias, as I said earlier, is the hematopoietic system, blood-related. Now, classifying cancers in terms of histology is looking at the tissue itself, and what we're doing is we're looking at the appearance of the cells and what is the percentage or degree of differentiation. So the more differentiated they are, the more closer they are to metastasize, and at that point spreading is a big risk as it gets from in situ and moves to metastasis. And what they look at, especially with histology, is how close does this tumor, if they gathered or collected, let's say with the biopsy, they send it to the lab, how close does this tumor resemble the tissue of origin? And remember, one way of thinking about cancer is cancer, we all have cancer in our body at this point in time, and our body is able to control it. It's just our body, we're constantly renewing our cells, and because of this constant renewal, there's very high risk for cells to grow more than they should. And what cancer ends up being is they're normal cells, in a sense, that are growing in an area that they shouldn't be. So if you have, and this is not exact, this is just to give you a conceptual idea, but if you have liver cells that are growing in the pancreas, liver cells aren't necessarily negative, but they're growing where they shouldn't be growing. And so a lot of times that they find these tissues that are absolutely not resembling the tissue of origin. So the closer the tissue is to the tissue of origin, the better the prognosis we believe it is. Now, poorly differentiated tumors, as I just said, have a poor prognosis than those closer in appearance to the normal cells. Okay. Classification, we use 4 grades to classify. Grade 1, 2, 3, and 4. In this slide, we have grade 1. In the grade 1, cells are slightly different from the normal cells, and they're very well differentiated. Cells 2 are a little bit more abnormal, and they're moderately differentiated. Grade 4, the cells are very abnormal and poorly differentiated. Grade 3, sorry, and then grade 4, cells are immature, primitive, undifferentiated, and the cell of origin is difficult to determine. So if you find a grade 4 lump of tumor or neoplasm in your lung, and you gather it and you run it through a lab to detect what grade it's at, they may not be able to say, okay, this came from the bone or this came from elsewhere, because they are so undifferentiated that they won't be able to determine where the lung cancer came from, or even if it was originating in the lung cancer. And so one way of thinking of grade 3, for example, is if you remember the word dysplasia, right? There's severe dysplasia at this point. With grade 4, they would use the word anaplasia. There's just undifferentiated. Undifferentiated is the best word, I think, to try to understand this at this point. This slide here is extremely important, together with the one that we'll talk about very shortly. Clinically staging classification. So you need to know that when you see the number 0, it means cancer is in situ, which in Spanish would mean en su sitio, in his place. It is where it was, where it originated. It has not moved. It has not start to go elsewhere. It is in situ. So you must know that term well. The clinical staging number one is where the tumor is still limited to the tissue of origin, and so it's still considered a localized tumor growth. It's growing a little bit, but it's not yet gone elsewhere outside. Definitely has not metastasized. Clinical staging 2 is where there's limited local spread, so it's still local, but it's now growing more. Staging 3 is extensive local and starting to go regional, and stage 4 is where metastasis is happening. So you should understand that by classifying it through the stagings, what we're really looking at is the extent and the spread of the tumor or of the cancer. And again, this is kind of like basing it on anatomic, because we do look at location, as opposed to looking at what does the cell appear like or what does the cell look like. So yeah, keep those in mind. This is an important slide for you to understand and remember. This one I put in bolded and red because it is also an important slide that you really need to know. And you can find more information in your table 15.5 in your book. TNM stands for tumor size for the T, spread to lymph nodes for the N, nodes, and M is metastasis, right? And not all malignancies can use this form of classification. Like, for example, leukemia, they're not a solid tumor, and so they're not going to be able to be staged. You won't get leukemia with the TNM. So it's mostly for the solid tumors. And cancer in situ that would be sort of like the T with a 0 or T with the IS for in situ. And that's more of a histological characteristic. All right, let's jump right into it here. So when we stage, again, the cancer, we're going to do it always at the initial, when there's first symptoms, when we first see through a scan, or it's bulging out somewhere in the skin. Somehow we know the cancer's there. A patient comes with symptoms and manifestations, and they scan and find, okay, there's a lump, there's something there. We don't know what it is. We always want to stage it initially, and then throughout as we evaluate the interventions. And again, when we do the staging, we break it down into clinical or surgical, and it's a very important thing to understand. Clinical staging is done at the completion of diagnostic workup. So when we do the diagnostic work, and we do that because we want to be able to effectively choose and opt for what treatment the patient is going to receive. And we can do that with bone, liver scans, ultrasonography, CTs, MRI, PET scans. So that's the clinical way of staging. The surgical staging is again, as the name indicates, where you do a surgical incision or an exploratory surgery where they go in and they cut a piece of it out, or they remove a lymph node as a sample, and then we can send it to a lab and determine the staging at that point with a sample. And exploratory surgery at this point, or surgical staging is not being used that much, as you can imagine, because the surgery is invasive, and if we have better alternatives that are non-invasive diagnostic methods of assessing for or staging, then we obviously want to try to use those more. And since science is improving, the surgical staging, just as an exploratory surgery, is less and less being used. Now, during, like, for example, using a laparotomy, and where they may go in for lymph node biopsies, they also can go in to look at the margins of any of the masses to see, if they're marked. They use that a lot during radiation therapy, but we'll get to radiation therapy shortly. So after the extent of the disease is really determined, we won't change the stage of classification. So the original description of the extent of the tumor will always remain part of that tumor, of the record. And if at some point additional treatment or interventions are needed, or if the treatment intervention fails, for example, then maybe retreatment staging will be done again to, again, at that point, redetermine or reevaluate the extent of where the disease was compared to the first time. So, and that we would call that, for example, with the TNM that we talked about earlier, that would be a restaging TNM. So if you see a little R in front of the TNM, that just means that it's not the original staging that first was done at the moment of diagnosis. It's just simply a reevaluation or restaging of the classification system. And so that's important to know. All right. When a patient has a possible diagnosis of cancer, always, if we don't have the results back, it's okay to tell the patient, I'm not trying to give you false hope here, but there are a lot of different types of neoplasms and tumors that are benign, that are not malignant. And so I would highly recommend, if at all possible, to not make any judgments or allow fear to affect you at this point. It's good to verbalize it and express it. We always want to listen to our patients, let them express what they're feeling, but we can provide them with the information that until we have further information, it's best to not make any judgments, and we definitely can't do that until we know for sure if it is malignant or not. And it can be a real pain in the butt, excuse my expression, but patients can go at the beginning, days to weeks of diagnostic studies. And during this time, fear is going to be a big fear of the unknown, right? Basically is what, and that can lead to a lot of stress. And that stress sometimes is worse than the actual, diagnosis of cancer. And, they're going to be overwhelmed. They're going to be confused. By the need for all these different diagnostic tests and studies and consultations. And so it's key for us nurses and family members to help them coordinate, the care between the different specialists that they're going to be seeing, and give them, explanations of why, what's the purpose of this test or that test, and how we need to prepare them for that. And again, with cancer, a lot of times if we catch it early, some cancers we can completely eradicate. Some hospitals will have comprehensive oncology teams and services, and that's great because these teams and oncology facilities can help do all of that care coordination, and they have cancer specialists, diet specialists, and so on and so forth. And these type of centers help consolidate the experience of the patient. And so with fear and anxiety, we always want to not give them a closed answer and just shut them off from them expressing their fear or their anxiety, but it just says, how do you feel like that? Or can you explain that to me? Or would you like to talk more about that? And sometimes it's very good for them to have that conversation, because concerns they may have that we are unaware of may pop up that will be good for us or case management, a social worker, or for their oncology team to know about in their prognosis and as they move forward with their diagnosis of cancer. Learning to recognize your own discomfort as a healthcare professional when you're talking to patients and having these difficult conversations is very important. We need to be very careful and watch out with the type of communication that may block the possibility of the patient, really, as I said in the previous slide, of exploring their feelings and meaning. What does this mean for them, right? And we also want to be careful with providing false reassurances. It's probably nothing. We never say that. But unless we do have the results back from the biopsy or whatever that says it's malignant, we can say, until we have those results back, let's not necessarily allow stress to affect us, because that's not going to improve your situation. And we also want to avoid to saying, well, let's talk about this later, right? Let's redirect the discussion to elsewhere. No, we want to let them express their feelings. And be careful with generalizing. Oh, we all feel like that. We don't know what patients feel like, so we can't really be taking that approach either. And then again, one of the most important things with healthcare professionals, watch out with using overly technical language. Try to bring the language down to a level where they can actually understand. Understand you, and so again, remember, listen to the patient. Listening is extremely important. So we all may have feelings of fears or concerns about cancer. We all may have had people who in our family have had it. And cancer is always linked to suffering and death, and we have our own feelings about it. And we may need to learn how to be able to express that in our conversations with our family members and with our patients. But what's very important is to allow patients to express and disclose their own fears and concerns. And so the reason why I say that we as healthcare professionals have our own fears and concerns is sometimes our fears and our concerns about our thoughts and beliefs about what cancer and suffering and death is, which could be very different from the patient who is sitting in front of us or in the bed in front of us. We need to not allow our fears or concerns be interfering with them and their ability to express what they have within, which is what their fears and their concerns are. So all in all, every patient who has cancer has to have a plan of care, and the plan of care is going to start from the moment that we as healthcare providers, professionals suspect that the patient may have cancer, and then diagnosis will ultimately follow through some type of abnormal screening test results or when symptoms appear again. And so what goes along with this plan of care is obviously health history, the HPI or history of present illness. Identifying the risks that the patient may have, doing a full head to toe, and then going into the many different ways of doing the diagnostic studies. And we're barely going to even touch through these. I would like to say that again, a lot of the studies are going to depend on where the site of the cancer is. And these are just some of the examples: cytology, X-ray, definitely a CBC with the chem panel, liver function studies, and maybe even some endoscopic examinations to see if they can visualize it. Other ways to diagnose them is we can do radiographic studies, radioisotope scans, a PET scan, tumor markers, genetic markers as well, BRCA, for example, and so on and so forth. One thing that I'd like to bring up with PET scan, and this is just an image A and B of a PET scan before, and A is the before the treatment and B is after the treatment. So if you look at A, there's a lot more areas that are lightened up or lit up for one sense. And I'd like to bring your attention to how and why what we do with the PET scan. So this is a tomography. And what we do is we give the patient, they can either put it through the vein, we give them sugar, radioactive sugar, and generally put it in through a vein. We wait for the patient for the sugar to be absorbed for 20 minutes, and we know that cancer cells absorb really high amounts of sugar. And then this camera, the PET, takes pictures that show the areas where the sugar is collected throughout the body. And wherever the sugar is gathering, that's where the cancer is. And so what we're really seeing, and I want this to come home to you, what we're really seeing here is a metabolic activity which lights up on the PET scan and is going to allow us, the medical professionals, the doctors who are going to interpret them, to detect where the cancer cells are throughout the body, right? And if you've had a PET scan before, like after cancer treatment, if the patient isn't required to drink a sugar beverage, then they're probably going to get it, an injection with that, what we call a labeled glucose prior to the scan. But I want to show you that we use sugar sugar to detect where the cancer is in the body. And that should be a pretty important factor for us to know. Again, in one of my previous lectures, I forget which one, would highly recommend you go to the TED Talk and listen to Dr. William Li, L-I is his last name, Li, and he's out of, I believe, UCSF, and he talks about how to starve cancer. He talks about angiogenesis. It's a very short talk, very, very worth watching, please. With diagnostic studies that we can do, of course, we can do a biopsy, bone marrow, molecular receptor status. With biopsy, some people in the naturopathic community, this is not yet seen as such within the allopathic community, but a lot of people believe that, if you're taking a small little tube, poking the skin, sending that tube that has these little clamps at the end, which are going to be able to bite off a little piece of the tumor that will, in order for us to send to a lab, you're taking this little clamp and you're directing it through the good tissue to where the tumor is. You're grasping a piece of the tumor, and then unless it's quite well sealed, so it depends on the instrumental, when you pull that back through, is there a likelihood of that cancer being spread through the good tissue? So that naturopathic medicine thinks that in some instances, not always, biopsies could be risk for spreading the actual cancer. Now that's not seen as such within allopathic medicine. They poo-poo that approach very much, in fact. So biopsies again involve, so when we classify cancers through the histology, the histological look of looking at the tissue through a microscope or electron microscope, the pathologist will look at that piece of the tissue, and we need to get a biopsy in order for that to happen. Now, we can get the tissue through a needle or aspiration. We can do an incisional procedure or an excisional and cut it out. Yeah, and so, all right, I'll save that thought I had for a little bit later. Well, actually, no, I'll go back there. There is different types. There's one of the ones that I think is important to know is the percutaneous biopsy, which is really commonly performed for tissues that can be relatively safely reached through the skin, as opposed to endoscopic biopsies, which may be used for lung or other, like esophageal, colon, not as easy to reach. And that's a little bit of a difference right there between the percutaneous and the endoscopic. I'm not going to expect you to know that right now, but I think it's good to keep that in the back of your mind. When a tumor is not easily accessible, even furthermore, than a surgical procedure, and we would call that a laparotomy or a thoracotomy or craniotomy if it's a brain cancer, and those may be necessary to obtain a piece of the tumor tissue. So again, depending on how accessible or where the tumor is, the level of intervention and invasiveness in order to get that tissue will be different. That I think that's important to know. Pathological evaluation of a tissue sample is the only definite means to diagnose cancer. So we do need to get a tissue, and we need to send it through pathology, and a pathologist needs to describe and what they're seeing. And we go off of that description from that one pathologist or a group or a team or a laboratory. And so the pathologist examines the tissue for a couple of reasons, three different reasons. One of them is to, again, figure out, is it benign or malignant? That's the bottom line, right, with pathology or pathological evaluation of a tissue sample. We also, examine the tissue for, the anatomic tissue for which the histology. So in order to be able to send it through a histology for better classification, I guess is what I'm saying, to find out where is that tissue coming from. So when we send it through histology, they can determine, of course, if it's differentiated, they may be able to determine where it came from, and thus we can determine the site or the origin of it. And then another reason is, to determine the degree of differentiation. Again, that's also histology for grading it. Okay, and so that's important to know. With cancer, all in all, there are risk factors that we can change and eliminate, and any of the risk factors that can be eliminated will help decrease the incidence of cancer. I mean, for example, smoking, rates of smoking alone or smoking related cancer, which we know are lung and even head and neck cancers, right, have been declining because people are smoking less. In populations that smoke less, there's less tumor, less lung cancer, for example. That's clear. So knowing that eliminating risk factors can help would obviously, and I would highly suggest that you keep in mind that sugar, even John Hopkins came out and with their stance on what sugar was, and basically don't do it because if you want to starve your cancer, don't give them sugar. And the problem with that is, of course, that if you eat simple carbs and drink a glass of wine, well, all of those converts to sugar. So the conversation is a little bit more complicated than that, than simply saying stop sugar. But the first step should be definitely stop eating those cakes, pies, cookies, adding sugar to your coffee, or drinking any high fructose corn syrup beverages. And so, really early detection and prompt treatment is going to be the best way to increase survival likelihood or chance with your patient, with anybody who has cancer. And we do things like colonoscopy, which can help reduce, colon cancer mortality. Of course, there's always a risk when you go in that you get, nicked in the procedure, depending on the skills of the individual doing the colonoscopy. And so we have to get a consent, of course, and let them know that, hey, there is a risk. But it can help in early detection of colon cancer, for example. And they even do sometimes colonoscopies to cut out like certain polyps that the body that they may have. So education is essential. And unfortunately, a lot of the slides that were provided don't give you a lot of the details in terms of what education we can provide our patients. But don't worry, I will provide that as part of our food for thought at the end of this lecture. And I highly suggest that you listen to the end, because it's pretty interesting. At least I think so. And I'll give you a couple of pointers that you may see at some point on a test, for example. So the goals of public education are various, and you can see it right here. One is to motivate people to recognize that they have power in their own hands to make changes. We would like to tell them to make radical, drastic changes in their lifestyle, but we suggest that we start with measurable, small steps. Stop one thing only: smoking. That's a great step forward. If you can then at that point stop drinking sugar-full beverages, great. Then we can expand it and start talking about processed foods. But we start to try to motivate them, let them know that you are not a subject upon which we, the healthcare professionals and providers, perform our interventions upon. You are the center of the care, and thus we need to let you know that without your participation in your own healthcare and what you do in your day-to-day life will help yourself improve. And so ultimately, really, there should be that motivation from the patient. And then we want to try to encourage awareness of the fact that there's tremendous health promoting behaviors that they may not be aware of. And I will give you this information. Unfortunately, the slides that I was provided with don't do that, but I have a few that I'll add in at the back, and I promise it's not going to be too much. So again, prevention and detection. So lifestyle habits to reduce risk. So what they're saying here is learn and practice the recommended steps for preventing breast, colon cancer, cervical, prostate cancer, right? Go through the cancer screenings, practice self-examination, like with females to have your husband or have the woman herself test for breast for her breast, for little lump, hard nodules that are not moving, or maybe for the man to detect unilateral testicular lumps as well. And then again, the 7 warning signs of cancer, um, and this is important for you to know. God, I should have probably put that into a slide. Obviously, change in bowel or bladder habits, constipation or diarrhea, urinating more or less, a sore that is not healing, unusual bleeding or discharge from any of your body orifice, thickening or a lump in the breast or elsewhere like the testicles, indigestion or difficulty in swallowing, obvious change in a wart or a mole could indicate that, and then a nagging cough or hoarseness as well is important to know. And I would gladly, but they're in your textbook, so do look at the 7 warning signs of cancer. Okay. I threw in a couple of these slides here because I do want to say that since education is essential and is extremely important, I personally believe that not enough attention yet, although that's really changing and fastly, I believe, in some cancer centers of the throughout our nation, is the notion that it's extremely important to support the body's ability to heal itself. So for one, the first thing is when we talk to our patients, we need to let them know that the drug, the chemo, the surgery, the radiation, the medication is not going to be what helps them the most. What's going to help them the most is to first come to the realization that their own body has the ability to heal itself given the right conditions. And I think I should have underlined given the right conditions. And so we need to talk to them about the risks of toxic substances in their foods, in their makeup, in their houses, and at their jobs. And then what we really need to do is, as Florence Nightingale would have us all understand, I mean, it's really that basic. This is not rocket science, and it's not something out of our scope of practice to encourage our patients who are already sick and ill to walk barefoot on the soil, to take a hike, to breathe air in, to practice some breathing therapies, to drink water that is filtered and healthy water properly with fiber, to get good body movements to move things through, eat food and nutrients that are whole and not processed foods, get your vitamin D, which is extremely important, and then even with electromagnetic frequencies, which I'll talk about shortly in a little bit. So what we do, or how we educate our patient in terms to let them come to the realization that ultimately it's their body that has the ability, not the doctor, the nurse, the surgeon, the oncologist. We don't do the healing for them. Their body does the healing for themselves. We can provide them with proper support so they can heal, their body can have everything that is necessary to heal itself, to improve. So the focus, unfortunately, of still, but changing drastically. I mean, it's really, really amazing to see what's happening today. But there still is a little bit of a lag behind this sort of new paradigm that's starting to come out in terms of conventional cancer treatment. For the most part, really, the focus still seems to be to destroy the cancer cells at all costs. And so, for example, that would be like saying, well, I'm going to give you everything anti. I'm going to give you an anti-hypertensive. I'm going to give you an antibiotic, antifungal, anti-parasitic. I'm going to give you an anti-malarial. I'm going to give you an anti-hypertensive. I'm going to give you an anti. And so we're doing all of these antis. And I am not against the antis. For a critical care setting and an acute care setting, they're extremely important. They can save lives, all of this sort of very invasive approach to help the patients can really help them. But together with that anti, we need to really be talking again about, well, what can we do for the patient to improve and feel better and be motivated and eat better. And so really we need to, and it's changing. I shouldn't say no emphasis. There's starting to be a lot more emphasis now in prevention, lifestyle, good nutrition, and overall avoiding stress and pollution and synthetic chemicals. including synthetic vitamins and nutrients and supplements. But why would one want to eat synthetic foods in the first place? That's what processed foods are. So a lot of times, unfortunately, a lot of patients who are on chemo or radiation, they're saying, well, get off all nutritional supplements as they might interfere with conventional treatment. Let me read that again. Patients are often told to avoid all nutritional supplements as they might interfere with conventional treatment. So from a nursing allopathic NCLEX perspective, that's what we should be saying, because yes, ginkgo, garlic, fish oil will all put them at risk for bleeding, so on and so forth. But really, if the body needs nutrients to allow it to heal itself, and yet we're saying to avoid a lot of the things that might be helping them. So what I would highly suggest with our patients is to try to encourage them to work with an oncology group that has a specialized trained nutritional therapist that understands which supplements and which foods can go together with their treatment. And there's a lot of cancer societies and cancer centers throughout our nation that are already doing wonderful jobs at this. It's just they're not all of them are there yet fully there. And so, often progress in treatment of the cancer is measured by, is the tumor shrinking, and how we use CT and PETs again. But this is really not a good measure of progress because it's not well correlated with longevity. You're considered cured if you've gone over. So if you die at year 5 in 1 day, so if you're over 5 years from the date of your diagnosis, and you die at the next day, you were healed, you were cured, and that's part of the statistics of people who are cured, which I think is slowly changing as well as our opinions change about that. Some patients, and this here is a very, very touchy subject, but again, bottom line with this slide, each and every individual, when you go to give medications to your patient, always the patient has a right to refuse. We do not force medication upon them unless they're at a risk of harming others or themselves. That's a different situation, but a lot of times patients that have cancer are left with really difficult choices, and they have to make decisions, a lot of times with insufficient information, and sometimes, for example, in a lot of the solid tumors, for a solid tumor to appear in scans, that solid tumor had to have been growing for a good 8, 9, 10 years for it to even be visible in many of the scans that are out there. And some of the scans are improving, but generally speaking, most of the solid tumors, they've been growing for a long time. And yet one of the unfortunate reactions that patients get from the healthcare professionals is rush, 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 hurry, 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 fear, fear, fear. And yes, there are circumstances where if they're fast-growing, glioblastomas, if the tumor is wrapped around a vital organ or the patient is at risk, then you want to do things stat. You want to get in, you want to do surgery, burn it, chemo, whatever you need to save the patient, absolutely. But by and large, patients should be told that, look, go home, talk to your family, sit with yourself, meditate upon what's going on, and what would you like for yourself, right? And a lot of people are making decisions that are going against what conventional treatments are. And guess what? That is okay, people. That is absolutely okay. Now, if you're a parent and you have children and they're underage and you're not giving them certain treatments, you could be held legally liable for not providing them the standard of care or the conventional way of treating it. And so this is a very anxious situation in terms of making proper decisions of how to move forward and what do we do? Do I do conventional? Do I do alternative? And I don't like the word alternative at all because, well, think about it, right? If alternative is the least invasive way to go, diet, nutrition, supplements, breathing, air, oxygen, and many other treatments that are out there, right? If the alternative is the least invasive and the conventional is really burn it, cut it, radiate it, surgery, chemo, and radiation, which are a lot more invasive, what I don't understand is how did the diet become the alternative to a more invasive therapy. And so the paradigm is slowly changing, but there is a very, very, very strong resistance to come around and realize that the invasive therapies should be the alternative to what are considered alternative approaches. We should always supply the body with nutrients. We should always supply the body with proper oxygenation, with proper de-stressing, work with them in their lifestyles, what's going on in your day-to-day life, and then as need be, add in the adjunctive treatments, but we don't call that. We usually call alternative therapy the adjunctive therapy. And so it's again, ultimately it's the choice of the individual to make the decision they want to make for their own body. And if the patient wants to go down the route of radiation and chemotherapy, by all means, that's their decision to make. And if the patient thinks otherwise, it is also their decision to make. With children, a different story. So again, prevention and detection of cancer. Again, don't expose yourself to cigarette smoke. Eat a balanced diet. Vegetables, fresh fruits, whole grains, adequate amounts of fiber. Try to reduce the bad fat, and definitely get rid of preservatives and processed foods. Get rid of smoked and salted cured meats. Eat more plant-based if possible. And then participate in exercise. Limit your alcohol to 1 or 2 glasses, depending on if you're a man or a woman, female or male. And then try to gain some weight, gain some healthy weight. So lose some weight if possible, or if you're skinny, make sure you get to a proper homeostatic balance. Cachexis and malnutrition or waste is not a good thing. Get adequate rest, eliminate, reduce, and cope with the stress that you're having. Change your perception about the stressors, and also try to enhance the ability to effectively cope with them as well. Have a regular health examination checkup, and know what your family history is and what your risk factors are, for sure. I'm going to take a sip of this while you read this question here. You should probably have guessed this. If you know that, if the highest number of cancer deaths by sight, right, are in lung and the bronchus. And what do you think is the number one cause of that? With smoking, I want to tell you is that at every visit, every time they come, smoking cessation needs to be brought up. It does not matter if they've heard about it before. Again, we have to respect their rights. If we bring it up and the patient tells you, son, I have absolutely no interest in quitting smoking. In fact, I am not going to do that. Then we can politely say, I'll say no more after this. I just want to ask you a quick question. Are you aware of how the tobacco and the nicotine is affecting you, and of the risks that it'll only make the situation worse if you continue to smoke? And if the patient says yes, then you can say, are you still adamant about your desire to just not quit smoking? And if they say yes, then you say, if you ever want to, while you're here hospitalized in the hospital, or if it's outpatient, say, if you just call us here at the outpatient clinic, we would be glad to point you in the right direction and give you the necessary support for you to go through smoking cessation properly. Chemotherapy, now we're getting into a little bit more of the treatment. This is not a pharmacology class, though. We can classify chemotherapy. So basically, every drug is going to be classified in how that drug works, and that's going to be either molecular structure or mechanism of action. Now, very important to understand, and if you were getting your certification of oncology nursing, which I have not done, but I do know I've floated to quite a few floors where they do give chemotherapy, and I know that 2 major categories are the cell cycle phase, that non-specific, and the cell cycle phase specific. And for example, the anti-metabolites are going to be specific, cell cycle specific. The mitotic inhibitors are cell cycle specific, and I think the non-specific are more like the alkylating agents or some of the anti-tumor antibiotics, for example. You don't need to know that right now, but do know that a lot of the drugs that we give, the chemotherapy drugs, are specifically targeting the cell cycle, which we should remember from our micro and our physiology as well. This is an important thing to remember because drugs can pose definitely an occupational hazard as to us healthcare professionals if we don't follow the safe handling guidelines. So knowing what to do is extremely important. And there's risks in handling body fluids or excretions of people that have received chemotherapy, especially immediately following administration. So anybody who's had chemotherapy in the last 2 days, their spit, their tears, their saliva, their urine, their stools could be contaminated, and so we need to follow the proper guidelines, double glove, and how to get rid of it. And the National Institute for Occupational Safety and Health, OSHA, have been the ones to develop safe and proper handling. So I'll just make sure that drugs can be absorbed through the skin. So don't allow any of their urine or fluids to touch your skin. And some of them can even be inhaled. So in some cases, you need to make sure you not only touch the medication, but don't touch the fluid or the fluids or excretions from the patient. And really, what you should know and learn from this slide is only properly trained personnel should handle cancer drugs. If you're pregnant, let the charge nurse know or the lead nurse know, because you don't want to be dealing with that. Cancer treatments, the goals we can either target, we can cure, control, or palliative, and these are three. And palliative is more of at a point where we're just simply supporting the patient in multiple ways as they go through their treatments, which are just to minimize perhaps pain or immediate risk of death, and to palliate them as the prognosis is probably going to be poor. And so it's important to keep that in mind. Here in this slide, it shows you, which is in your book as well, when you start with the initial treatment therapy or phase, it goes through the diagnostic, perhaps get radiation, chemo, or surgery, maybe an immunotherapy, which we'll talk about here with 2 or 3 slides. But immunotherapy in and of itself is a huge area, and I'm definitely no expert in that area by any means. But when we talk about cure, basically it's a constant follow-up phase after the intervention, and if there is no return of the cancer, then they go back to their usual day-to-day life and living, and it's considered cured. Control is where they may not yet be palliative, but they're constantly having to go through the retreatment phase of radiation, surgery. So they may get it in the first initial treatment phase, and then that may repeat itself again if necessary, and if the cancer happens to return or was never fully eliminated in the first place. And that's the goal of the cancer treatment at that point is just to try to control it and keep it from spreading first and foremost. And then palliation as a goal of treatment is where there's no response to the initial treatment at all. In fact, it might even have gotten worse. And so, again, there may be another treatment phase to see if we can get it into control. But once that disease phase advances, then we get into what we call the supportive phase, and a lot of times in patients in the hospital, we'll put them on a morphine drip, and we at that point is just to keep them as comfortable as we possibly can. And they may end up having hospice care. Usually, I believe the doctor has to sign a paper claiming that the patient will probably not live within 6 months in order to get them into hospice. All right. So the role of surgery and treatment, when we're trying to consider the surgical intervention, again, it's going to depend on assessing the tumor stage, right? Is it local or has it metastasized? elsewhere in the body, because that's going to determine the effectiveness of the treatment that we give. And the objective ultimately of surgery, for example, is to remove all or as much as resectable or as possible of the tumor while sparing normal tissue. So if they go in to try to cut it, and this is where I think, the genetic may not be necessarily the full explanation for why that's the situation or the case. And I'll explain why. Because if you go in and you have a piece of tumor and you cut inside and remove, not only do you remove the full tumor, but you cut even a little bit more into the positive tissue, the tissue that is not considered tumorous, to ensure that 110% of the tumor has been removed, more than necessary. Then if that tumor grows back again, wouldn't you think that metabolically speaking, something is happening in the body that leads for that tumor to come back? That's just a quick little thought. Now, what are the goals of chemotherapy? Now, chemotherapy can offer cure for some cancers, control for others, and that may go over long periods of time. And in some instances, maybe they do it for just palliative or relief of symptoms when cure or control is not possible. So in a lot of the, like Wilms tumor, neuroblastoma, testicular cancer, if caught early enough, chemotherapy can really do great things and completely reverse it. But then again, we still want to have the conversation with the patient about lifestyle and diet, because if they go back to doing what they're normally doing on their day-to-day base, what's the likelihood of that testicular cancer coming back? Even if they fully removed it with surgery or chemo, if they don't change what they're doing, whatever they're exposing themselves to is going to, epigenetically, is going to be, will re-trigger the phenotype expression of the disease, and they'll get that tumor back again, the neuroblastoma or testicular cancer. Usually in breast cancer, small cell lung cancer, non-Hodgkin's, ovarians, a lot of times that's control. Although a lot of people with breast cancer have been able to control it as well. A lot of the people I know have controlled it again through a combination of chemo, radiation perhaps, and lifestyle for sure. And then palliation, as we said, is just to help the patient feel better and suffer less. So chemotherapy can be given, as you can see in your book in table 15.8. Make sure you look at that. It can be given PO, IM, or IV. IV is most commonly given. We give it through a central venous device or central catheter of some type. You do not want to be giving it through a peripheral. And you have to be very careful. And nowadays, there's a lot more. There's regional treatment that can be given with chemotherapy that is really delivering the drug directly to the tumor site. And the most common ways of doing that is intra-arterial, intraperitoneal. They can do it intravesicular or into the bladder, for example, or intrathecal or intraventricular. So they can go in specifically to where the tumor is and inject the chemotherapy right to the local region as well. And that is another form of chemotherapy. Now, I bring this image up here so you can get an image in your mind as to how dangerous chemotherapy can be. They're tremendously dangerous irritants, vesicants that can clearly damage the vein, and they can cause not only phlebitis but sclerosis, and can limit future peripheral venous access in the future as well. But it can clearly, as you can see in this picture, cause tissue damage if infiltration happens. So be very careful, and with especially the antineoplastic drugs, because extravasation, which is basically infiltration of the drug into the tissues surrounding where you're infusing, can really end. Some people have ended up with amputation. So it's really extremely important to monitor for and really recognize symptoms of extravasation of the drug you're giving and take immediate action. Otherwise, things like this or amputation could end up happening. Sorry, I'm going to take a quick sip here. chemotherapy methods. So the central venous devices usually are put into large blood vessels, and be careful with a lot of the periphery, especially if they're hard sticks, because of that extravasation. It's very dangerous. And you know, and with frequent continuous intermittent administration, you always if the pain starts to complain, if the patient starts to complain about pain in that area, the first thing you always want to do, just make sure the first thing you do is stop the infusion of whatever you're giving. Obviously, patient safety first, and then you can assess for what's going on and look and see what's going on. So you wanna minimize physical discomfort and risks of infection, and especially of infiltration. Regional administration of chemotherapy have also been developed, and again, these are where they go through into a special area, like intravesicular bladder chemotherapy, or intraventricular or intrathecal, intraperitoneal, intraarterial. So the artery, the peritoneum, the thecal, ventricular, things of that nature. One thing with the intravesicular bladder chemotherapy, though, because it's going through that area, we have to be very careful with the stools that the patient may end up having, and we want to make sure that we're not giving them too much fiber. So low fiber diet, low roughage diets for patients who are getting intravesicular bladder chemotherapy, because that could irritate. Remember, for up to 2 days, that they're at risk. Well, it's in their body and now needs to come out of their body. So if it's going through the bladder, the urine or the stools could put them at risk in many different ways. And so any fluid, body fluid, is contaminated. And again, a lot of times with chemotherapy, patients end up passing away or dying because of the complications of the treatments that we're giving them in the first place. So we have to keep that in mind as well. Now, intraarterial or intraperitoneal, which I just mentioned, the intraarterial, for example, is used for some different types of sarcoma, and cancers of the head and neck or bladder. Melanoma, I think, is one that they use that for too. And for liver cancer as well, they use that significantly for liver cancer. The intraperitoneal, as opposed to the intraarterial, is generally infused into as the name says, the peritoneum, with 1 or 2 liters of fluid, and they allow the fluid to sort of sit there in the peritoneum area for 1, 2, 3, maybe up to 4 or 5 hours. And after that time that the fluid has been sitting there, then they'll drain it back out of the peritoneal area. And so that's important to know. With the intrathecal or intraventricular, they're used usually for cancers that metastasize to the central nervous system, which are very difficult to treat because obviously, the blood-brain barrier is often a barrier, as the word states, to prevent the chemotherapy drug to get to where we want it to get. And then the intrathecal chemotherapy could be given through a lumbar puncture, or an injection of the chemotherapy into the subarachnoid space. And to reduce the need of repeated lumbar puncture, sometimes patients may have certain types of maybe not permanent but temporarily God, what was the name of that? I'll get back to you on that. Reservoir that they put in to be able to go back in and access the Ommaya. It was the Ommaya reservoir, which you don't need to know, but I've seen a couple of them, and a lot of patients they even go in surgically or implant them through the cranium into one of the lateral ventricles. Chemotherapy-induced side effects is a huge problem because we know that chemotherapy destroys the cancer cells, but also the normal cells. So we're giving them a treatment that is not only not assisting them to support their body, which nutrients and other things of that nature would be doing, but we're killing the normal cells, especially those that are, in like the bone marrow, or the GI system, or the skin and the hair, because they're more rapidly growing. And so again, side effects of chemotherapy is they destroy normal cells. And so we have to think about that in terms of acute toxicity will occur or could occur or most oftenly occurs or immediately after the drug is being given. Sometimes they may go into anaphylactic shock or have a hypersensitivity reaction, the type 1 hypersensitivity, remember that? The IgE sort of allergic reaction. They can have extravasation. They can have nausea and vomiting. With a lot of patients, we need to, if they have nausea and vomiting with these treatments, just give them the antiemetic before, Zofran or ondansetron. And some patients may end up going into cardiac dysrhythmias as well. So keep that in mind. Now, there may be delayed effects. Patients could have chronic toxicities, which could damage organs like the heart, liver, kidneys, lung, and they could have long-term effects that could develop again immediately or maybe significantly further down the line. Really, late or lasting effects of chemotherapy will make a huge difference on whether the patient survives or not. So again, that's just saying that chemotherapy is oftentimes, or the complications of chemotherapy. So the treatment is the cause of death in a certain sense, is how we have to be looking at that. Cancer treatment, radiation therapy. Now, that said, I will say that as science improves, a lot of times generalized treatments are not used as much anymore as our specific targeting of the tumor in the area. And I gotta say, the promise for treatments coming out is just growing exponentially. So we have to be careful with having exclusively just a negative attitude towards cancer treatment overall, but really chemotherapy and radiation, we do need to inform the patients that they have risks, and it's up to the patient to determine if for their quality of life that they want to live, if it's worth it. So cancer treatment using radiation. So we use surgery, we use chemo, and radiation is one of the oldest ways of treating. But that's been around since, late 1800s, I believe. 50% of all cancer patients that will eventually receive radiation therapy at some point. So let's cover a couple of things here with the radiation treatment. So there's different types of ionizing radiation that they use to treat cancer. X-rays, gamma rays, those are like electromagnetic radiation, or particulate radiation. Those are more specific, like smaller particles, electrons, neutrons, protons. Now, they can use really fancy new linear accelerator machines where they use more high energy X-rays or photons as well. And so again, this is just basically technology that's advancing and refining itself to fine tune how radiation is being delivered and offering much, much more accurate and significantly less invasive radiation treatment options. And this is really, it's a great thing. It's still radiation, right? Most radiation centers in our country still use that sort of mega voltage accelerator. Those are the larger radiation facilities that they can give it a combination of different types of machines or treatments that'll permit, that'll help the patient go through their treatment options. And so, again, talking about their options, what are those options? Well, again, there's low energy and high energy, as I just mentioned earlier. And as radiation is going to be beamed through, energy, basically you're taking energy and depositing it at the site of where the cancer is. And, technically speaking, most of the cancer cells or all of them could be killed with radiation given in high enough doses. So you have to bombard the area with high energy fields significantly in order to get the results that you want. However, to avoid, again, not unlike chemo, there can be serious toxicity, and to avoid that toxicity or long-term complications, a radiation which can affect the healthy tissues as well, it must be limited to whatever the maximal tolerated dose for that specific tissue is. And that's quite a complex thing that we don't need to understand, but each tissue does have a maximal tolerated dose, and we need to be aware that everybody that is getting radiation treatment, once they reach that maximal tolerated dose, they can't get any more bombardment of that radiation treatment. Now, as radiation only has an effect on the tissues within the treatment field, it's not appropriate as the primary treatment for systemic disease overall. Again, it's not a primary treatment for systemic disease. That's important to know. It may be used by itself, or more oftenly, it's used in combination with chemo or surgery to treat some of the primary tumors, and it can be used for palliative or palliation of metastatic lesions that the patient has developed. This is important to know and keep in mind that radiation can be delivered externally or internally, and I want you to know that the external form of radiation, when we deliver it externally, we call it teletherapy or external beam radiotherapy, and internally we call it brachytherapy. Okay, and so teletherapy or external therapies when radiation is given externally. Again, remember, internally is brachytherapy, but right now we're just talking about teletherapy, not brachytherapy, right? So when you have an external beam, there's a lot of things that you need to keep in mind with teletherapy or external beam radiation, right? So if you give it to the abdomen, for example, a radiation to that area will affect the organs within the pathway, like the bowels, and it may cause them to have frequent diarrhea. So we have to teach the patient to clean the perineal area really careful after every bowel movement. And again, this is where we eat a low residue diet to avoid irritation to the bowel, especially with external beam radiation. Now, again, external beam radiation can lead to fatigue, and the patient may end up being really tired, and they may end up having a really great difficulty getting out of bed. I'm going to tell you this is extremely important to keep in mind right now, especially in the acute care setting when they're in the hospitals. We need to keep them active. Even if they're having difficulty to get out, they have to be participating in a walking program to keep them active without excessive fatigue. Because if you minimize their activity, it's only going to lead to more weakness and perhaps even complications of immobility. So we need to keep them active. Again, with external radiation therapy, we have to teach them to avoid swimming in salt water or in chlorinated pools during the treatment, because there can be an interaction there. With external beam radiation therapy, it can lead to a dry or desquamation of the skin. So again, iatrogenic, caused by the treatment. We give them external beam radiation and they get dry or desquamation. I put some photos later that you'll see what dry or desquamation of the skin is. So if it's dry desquamation of the skin, you can use things like aloe vera. Absolutely can use things like aloe vera and cream on the radiated skin areas. Pay attention to what I'm going to say. Do not use ice or sun lamps that could harm the skin. Okay, do not use ice or sun lamps that could harm the skin. Treatment areas should be cleaned really gently. Don't rub ever really hard because you want to avoid further energy. So those points that I said, I would highly recommend that you pause, go back and re-listen to them, because I gave you 3 or 4 points on this slide that are key for you to understand. Common side effects, again, we have an important role in helping patients to deal with a lot of the side effects in chemotherapy or radiation. And I will say one of the most common things that we see in a lot of our patients is neutropenia, especially in patients, with chemotherapy above all. So educating patients about the treatments and supportive care. And supportive care a lot of times is pain medication, antiemetics, antidiarrheals, and we should teach them to, what are they going to expect throughout the course of their treatment, right? Because keeping them informed is going to, again, remember that talk that we had about fear and anxiety, keeping them informed at all times rather than just walking in and giving them the medication. Why are we doing it? This is what dose we're giving. Why are what our what some of the side effects are? Please let me know if you feel burning, things of that nature. We have to keep that communication open. And again, before initiating teaching, make sure we assess patients' ability to process information. If they're knocked out, drugged up, if they're on palliative care, on morphine, drowsy, they may not be able to retain. At that point, we may need to customize it to teach their spouse, their relative, their partner, or their family member, or their caregiver. And again, nursing management of patients with cancer really is looking at, the treatments or the interventions to counter the effects of a lot of the problems or complications. And some of those complications could be, myelosuppression, right? The bone marrow, or thrombocytopenia, or anemia, or nausea and vomiting, or anorexia, or stomatitis, diarrhea, constipation, mucositis, skin reactions. Again, these are all common side effects. So we need to inform our patients. That's why we always like to have informed consent. Fatigue is almost a universal symptom affecting most patients with cancer. It can persist even long after the treatment has ended. So we need to encourage them to try to keep some routine exercise in, because the last thing you want to do is allow that fatigue to weaken them even more. Anemia is one of the causes, could be one of the causes of fatigue. But there could be other reasons, right? Mitochondrial dysfunction or accumulation of toxic substances. Well, the treatments we're giving them are toxic substances. And if they're left in the body after the cells are killed, a lot of those cells need to be somehow gotten rid of by the body. And that toxin buildup can lead to a lot of the problems. And, the need for a lot extra energy to repair and heal the body tissue that's been damaged, and maybe even they lack sleep, which could be caused by some of the chemotherapy drugs as well. So you get the idea. These drugs are not without complications. And so I guess bottom line, we do need to let them know that because these treatments have pretty serious side effects, one of them being fatigued and so on, we need to maintain an exercise and activity within their within whatever their baseline of activity is, because that will be one of the key things to help them manage the fatigue. That's essential. With radiation, skin effects could be local, and it's going to be where the treatment field where the skin was exposed to it. Radiation-induced skin damage is what we're really talking about, and that the changes that you can see could be acute or chronic, depending on the area that was irradiated, and depending on the dosage as well. And so, usually a lot of the areas where skin folds happen, or where pressure ulcers can happen, behind the ear, gluteal folds, perineum, like the breast area. So we have to make sure we do our assessments properly on patients who are having these type of treatments that could lead to these acute or chronic problems. Here is the image of we may call this erythema, and this is basically dry desquamation of the skin in an acute response, followed by a treatment. And dry reactions are really uncomfortable, especially itchy. So pruritus, controlling pruritus, whether it's through antihistamines or lubricating the dry skin. Remember, non-irritating lotion. No metal, no alcohol, no perfume, no additives. So something natural like aloe vera is very good for dry desquamation, and you need to know that. Wet desquamation. So Remember, cells slough, die, and regenerate. And so as they get treatment, if the rate of that cell sloughing or dying is faster than the ability of the new skin or the new epidermal cells to replace the dead cells, what we end up having is this wet desquamation, and that's going to occur with exposure again of the dermis, and ultimately what you'll see is weeping of serous fluid. So that's why we call it wet. And wet reaction must be kept clean, protected from further damage, this can be very painful. And again, these patients are at a higher risk for infection. So do not use heating pads, do not use ice packs, do not use hot water bottles in any of the areas that they've been exposed, the treatment fields. So keep that in mind. That's the most important thing here. Obviously, facilitating wound healing diet plays a major role in that. And avoid constricting garments, chemicals, deodorants, and even help patients deal with hair loss. And one way of doing that is they can go into, especially if your hospital has a little boutique for cancer patients, they can get a wig, help them choose a wig, or have a family member be present and help them choose wigs as well. And look up, of course, I would highly suggest that, if they use makeup, just try to use makeup that's not going to be putting more toxins into the body. That's the last thing they need. But usually, unfortunately, that conversation doesn't tend to happen. But as healthcare professionals, it should happen. Chemotherapy and radiation, again, as treatments, have the potential to hurt and damage the lung. Pulmonary tissue could be affected, right? And oftentimes that can be progressive and end up being irreversible. So we must be able to distinguish between, the complications of the treatment as opposed to those related to the disease. And that, my friend, is extremely difficult to do. How do we know that it's the cancer that is leading to the problem as opposed to it's iatrogenic and we are causing it with the treatment and the therapy that we're providing? So immediate pulmonary effects, for example, of radiation, could be really scary and fearful, frightening for the patients because they end up mimicking, what in the first place. So they get a cancer diagnosis of the lung, they go, which produces dyspnea, shortness of breath, and cough and whatnot. Now we give them radiation, and they end up having the same symptoms that they had when they first got their lung cancer, and they have cough and dyspnea and all of that. And so that's something that needs to be thought about and considered. And, pneumonitis or pulmonary fibrosis, even pulmonary edema, and many other lung problems can be produced by that inflammatory reaction going over and happening chronically. And ultimately what that means is that where the gas exchange, the alveolar capillary area is damaged and going to put them at a lot higher risk for further lung complications. Cardiovascular, again, radiation and chemotherapy have the potential to produce not only progressive cardiac toxicities, but sometimes even irreversible. So iatrogenic, we caused it. It is us and our treatment that led to them having the problem. And a very common one that happens is pericardial effusion. And again, that's iatrogenic. I love the word iatrogenic. It's a complication. It's a fancy word for saying we caused it. We, the healthcare professionals in our treatments and interventions, caused it. But yes, that is a reality of chemo and radiation therapy. ECG abnormalities, left ventricular dysfunction, heart failure, low decreased cardiac output, everything we've talked about in our cardiovascular lecture, including arrhythmias, and fatalities, are side effects of a lot of these treatments. And so we should be monitoring a lot of them in terms of we should be monitoring their cardiovascular system closely. Cognitive effects can happen at any time, especially after the treatment, but maybe even during. And it's an alteration in you're in mental function. There are levels of consciousness, altered levels of consciousness, ALOC, that we commonly hear about. And it's really, they describe it usually as it's cloudiness or foggy, or they, we often even use the word chemobrain, right? And again, this will affect their thinking and memory problems, and that can be a problem for them as well. And although the brain can usually recover over time, the effects can last short time, or they can last for years. That chemobrain can last for years, and the effects can be so severe, in fact, that patients may be unable at a certain point to be involved in any activities that require mental effort at all. If they're a student going to school, it could be so permanent they may have to quit school. If they have a job and they have to go to work, they may end up having to quit that. If they have any social activities of going out with friends, jogging, fishing, swimming, they may have to cancel that. That's how severe these cognitive chemobrain effects can be. Yes, yes, yes. Reproductive effects. Well, we know, again, radiation treatment, especially with the alkylating agents, can affect patients and lead to reproductive and sexual issues like impotence in men, fertility in a lot of the women, which is why if you're a nurse and you're pregnant or want to get pregnant, don't deal with chemotherapy drugs. Ask for another nurse to take the patient. And sometimes before treatment happens, they may need to do a pre-treatment harvesting, right, of the sperm or the ova or the variant tissue. Might need to be part of the conversation, or at least considered, right? And again, the testicles are highly sensitive to radiation, like many others organs, and the testicles should be protected with the testicular shield whenever it's possible. And then the radiation dose can even induce ovarian failure or it changes over time. And unlike the testes, though, there is no way to repair ovarian function. There is no way to repair ovarian function. Immunotherapy. I'm not going to go too much into that. There's various types of immunotherapy. Some cytokines, which chronically, can be, the complement cascade leads to a lot of the cytokine releases. Well, some of those cytokines, we know that acutely or short term, like interleukin-2, for example, is one that can be used as a therapy. But vaccines, monoclonal, look at table 1513 in your book, table 1513 in your book for the different immunotherapy modalities that are out there. So you can get a good idea. The monoclonal, one thing that I do want you to know, again, this is not a pharmacology, but you do need to know, the monoclonal antibodies are usually drugs ending in MAB, M-A-B, and they're by far some of the most successful immunotherapy treatments out there right now. I won't go into any of the others, the antibodies or the targeting one, but keep that one in mind, okay? Out of that slide. Side effects, one of the most common ones is flu-like symptoms, and again, the release and action of a lot of these immunotherapies that are targeted can result in systemic immune or inflammatory response. And the toxicities or side effects of a lot of these immunotherapies they're going to be related to dose and schedule and how often the patient has received it. Again, a lot of times in patients that are going under immunotherapy, this is important to know because they develop flu-like symptoms, they may end up getting large amounts of fluids and to help decrease the severity of the flu-like symptoms, and even acetaminophen. So hydrate them and give them Tylenol. Now remember, Tylenol used to be 4 grams or 4,000 milligrams. Now they're lowering it to 3,000 milligrams or 3 grams because of the risk that Tylenol has to damage the liver. Okay. There's a wide range of neurological deficits observed with like the interferon or the IL-2 therapy. That I talked about earlier. But, tachycardia, orthostatic are very common. And of the central nervous system, there's a vast array of what those neurological deficits could be. They can be very frightening to the patient and the family, who must be taught previously to observe for neurological conditions or problems. So we need to teach them about confusion, memory loss, difficulty making decisions, insomnia, and to report them so that we can take the appropriate measures of safety and supportive measures. And again, hepatotoxicity, liver and kidney, which are organs of detoxification, organs of elimination, can be affected by immunotherapy. Complications of cancer may develop, again, because the cancer grows, and more likely than not because of the side effects of the treatment, which is what we've been talking about all along. Malnutrition, a lot of patients with cancer could experience malnutrition, which for the most part means protein deficiency, including nutrient deficiencies. And yet, a lot of these patients are told to not supplement them, with more nutrients. That is slowly starting to change. Again, electrolyte depletion is a big problem. Dehydration is a problem. Weight loss. And again, if they're having malnutrition, which is a protein problem, they need the protein, and also they need it because they may be having an impaired wound healing. That is important to know. So keep that in mind. Let's see what else we have here. And again, if they're going through treatment in a center that has nutritional counseling, that is wonderful, because their proteins and calories can be measured properly, their weight can be monitored properly. They can monitor even albumin or prealbumin levels, because that's what looks at a lot of the protein ability of the body or risk of going into malnutrition, I should be saying, and also if that malnutrition is being solved with the proper nutritional counseling as well. In some patients, we may need to teach them to use nutritional supplements, and some of them may end up having to have enteral or parenteral nutrition if they're unable to eat or swallow or absorb any of the food that they do eat, or they're having nausea or vomiting constantly because of the treatments they're getting. They may very well be put on enteral or parenteral food treatments. They may end up having altered taste sensation, like they may end up having sour or salty taste sensations. Meat sometimes in a lot of the patients can taste bitter or bland, and frequently the patient may feel really, compelled to eat just very specific foods because that's what they feel better and that's what they believe is more beneficial. Lemon juice, onion, mint, basil, fruit juice could improve the taste of certain meats or fish. In some cases they say ham may even enhance the taste of vegetables. Go figure there. I wouldn't highly like that or suggest that personally. But some patients, if you ask them to, increase the amounts of spice or seasoning that they use when cooking, is not necessarily going to be the best way to enhance the taste. Wasting syndrome, anorexia, unintended weight loss, cachexia, generalized tissue wasting, skeletal muscle atrophy, immune dysfunction. The best management for cancer cachexia is to effectively treat the cancer, first of all. Unfortunately, it's not always a realistic goal for patients who have advanced cancer. So then a second option would be to increase nutritional intake. But again, this does not completely reverse a lot of the wasting associated with cachexia. So maybe a third option would be to give them Megace or Megestrol, which is a synthetic form of a hormone, a progesterone hormone, I believe, which ends up stimulating appetite. So remember, Megace or Megestrol stimulates appetite, and a lot of your patients will end up having that to stimulate their appetite and get them to eat a little bit more. Complications of cancer infection, that's usually the primary cause of death. Usual sites of infection: lungs, genitourinary, mouth, rectum, peritoneal, or blood infection. Complications, again, due to, a cancer infection can occur due to ulceration or a compression of a vital organ by a tumor, or neutropenia, and they don't have the ability to mount the defensive reaction, and that can be caused by the disease or the treatment. Pain is really important to know. Remember, patients should be educated to report what their pain is, and drug therapy should be given around the clock, not when they say they have pain, but around the clock scheduled to prevent the pain. So we need to inform patients a lot of times they have cancer to not wait for them to have the pain, but to take the medication TID, BID, and then just use a PRN if the pain is still not properly managed. So again, it's really important to determine between, is it persistent? Is it episodic? What type? Is it positional? Is it breakthrough pain? So we have to do a really good pain assessment to get a good detail of what is leading to that pain. That's the most important thing of this slide, is that, again, when you do your pain, ask about quality, location, intensity, duration, precipitating, what causes it, and what alleviates it, right? And then assess for pain on an ongoing basis to determine the effectiveness of the treatment. And that's important to know. Look at table 1520, which presents, assessment questions that may help facilitate our assessment. Management of cancer pain, for example, that can go with non-steroidal, anti-inflammatory, opioids, pain medication as needed, and teach them to keep a pain management diary, what led to it, right? So there are quite a few numerous drug options for pain management, and we can discuss the goals of what analgesic therapy should be. Especially for those who have chronic pain, they may need chronic doses of opioids. Treatment plans really should always be developed to balance, control of the pain, the analgesia, with the side effects that they may be getting, in order to really, our goal is ultimately to maintain optimal functional status, as optimal as we can possibly get. All right, so now I have a few slides. We're wrapping it up. We're coming to the end here. Again, I want you to pay attention that what we're doing here is food for thought. Do not think about all of this as a fact, but as healthcare professionals, I think it makes sense for us to be able to learn how to be evidence-based practitioners and read the data, read the science, read the literature, and we don't want to fall for everything that anybody, there's so much out there that is false, so we need to think critically. And yet we also want to be able to not fall into the pit of not being open to alternatives and possibilities. That's how science moves forward, is with openness. So what I'm getting ready to say, a lot of this information, let's consider it a hypothesis as opposed to a fact, which we as healthcare professionals ought to always be open to, right? Not simply believe everything that is told, but let's look at the data. Because if you lose, or I lose, or we lose that openness, we're going to not be evidence-based healthcare professionals, and we're going to risk becoming nurses who simply act out algorithms. We're task-based, and at no point will we be thinkers. So let's think a little bit. Let's go through some food for thought. This is a slide that just we saw earlier. The National Cancer Institute talks about cancer as a nuclear genetic disease. So let's look at that. Is it a nuclear genetic disease, or is it a mitochondrial disease, right? Current conventional cancer treatment and diagnostics have significant problems, and are contributing to a lot of poor results for a lot of the cancer patients, which is why new cancer centers and the new paradigms of treating cancer is starting to develop. And we need to be aware that this change is happening, because we're right dead center in this paradigm change, and we need to be careful about falling behind and not realizing that, hey, if there is new evidence that is valid coming from reliable sources, we should be willing to open our old way of thinking and adopt that. Now, alternative treatment protocols really have the potential to be competitive, if not even superior to a lot of the conventional treatments. They should be considered in many cases as primary, not as an alternative, or as a supplement option for the most invasive treatments. So let's delve right into this. This is a very important slide. Dr. Thomas Seyfried from Yale University, who wrote a book, Cancer as Metabolic Disease. They did some research in multiple universities throughout our nation, and I want you to ponder upon this. So green means you have a normal cell. It doesn't matter if inside the cell you have a little bit of a red. Green means it's a normal cell. The full cell, if it's red, it's a cancer cell. It's a tumor cell. Okay? So let's start with number one, all the way at the left. What do we see? We have a normal cell. What do you think when that replicates it's going to produce? Normal cells. Make sense? Two, you have a tumor cell. What do you think that tumor cell is going to reproduce? When it does reproduce itself, what is it going to reproduce itself into? Tumor cells. Should be simple, straightforward. Here's the key. Let's look at number 3 and 4. And what we should be thinking when we look at 3 and 4 is, if it is a genetic problem, right, then wherever the DNA and the RNA is, which is in the nucleus, then cancer cells should be formed. But let's look at this. If you take a normal cancer cell, by that it has a very normal cytoplasm. The cytoplasm where you have the fluid, the gel-like fluid together with the mitochondria. If you have a normal cytoplasm, but your nucleus is tumor, you have a tumor nucleus where all the DNA and the RNA is, what type of cell do you think that cell with the normal cytoplasm and a tumored nucleus is going to produce? Cha-cha, cha-cha. When it replicates normal cells. Wait a second. I thought it was DNA. If it's DNA, how can tumored nucleus, which is where the DNA is, reproduce to normal cells that just have tumored nucleus? But they're essentially they're normal cells. Now let's look at the fourth. This is where it becomes very interesting. Thomas Seyfried listen to some of his talks on YouTube, and again, this is just food for thought. If you take a cell that has a tumored cytoplasm, but the nucleus is normal, in other words, the DNA is unaffected, what does that cell reproduce when it reproduces? It reproduces a full tumored cell. That should be food for thought. So this is the gentleman right there. His name is Thomas Seyfried, and he says that the nuclei of cancer cells in normal cells do not result in cancer cells, but the mitochondria of cancer cells in normal cells do result in cancer cells. Wow. Take that for a thought process and chew on that. This is tremendous food for thought. So, by health and healing. So, an alternative or an adjunct to conventional care is to, again, try to think that the body has the ability to heal itself given the right conditions. This is a repeat of one of the slides that I talked about earlier. Reduce the exposure to toxins and toxic energies, supply the body with the needs, which are the macro, micro molecules, give them the proper foods and the proper dosages, give them the proper nutrients, get rid of sugars, get rid of processed foods, give them oxygen, proper filtered water, food, and nutrients, sunlight for that vitamin D, and maybe consume some vitamin D, and the PEMF frequencies. The PEMF is when you take electromagnetic frequencies, a mild electromagnetic frequency, I should say, therapy, and it can end up slowing or stopping the release of pain or inflammatory mediators. It increases blood flow to the cell. It can help reestablish normal cell interaction, and with reduction to all of this inflammation and pain and energy increases, fast tissue healing occurs, right? So I went to PubMed, and there are thousands about these. I just brought one little thing out there to show you that says that, if you look at the conclusion of this, where they looked at pulsed electromagnetic fluids for impaired breast cancer tissue, right? At the conclusion, it says, based on our data, it appears that PEMF-based anti-cancer strategies may represent a new therapeutic approach to treat breast cancer without affecting normal tissues in a manner that is non-invasive and can potentially be combined with existing anti-cancer treatments. We always like to bring in, we don't want to get rid of the chemo and the radiation too quick and too soon if they're effective, but if new data is starting to come out, why not? So especially given that PEMF is safe, non-invasive, non-toxic, there's little or no risk of an unfortunate interaction with any of the other treatment therapies or treatments that the patient may be receiving. By all means, if this is a non-invasive, I say we start looking at that for sure. Alternative understanding of cancer. This is a world in and of itself, but seeing cancer as a genetic disease results in tremendous limitations to treatments, as evidenced by the failure of conventional oncology to really make significant gains with treatments. The gains have been gained by education on quitting smoking and changing their lifestyle. So whatever gains we've slowly been making, there may be some that are in treatment, but for the most part, they're made because of lifestyle interventions. Now, cancer can be viewed, so if we start thinking about it by not necessarily only a genetic disease, which it is in a certain sense, can lead to profound differences in treatment. Cancer can be viewed primarily as disease due to damage to the mitochondria of their cell, not the nucleus. And Dr. Warburg, back in the 20s, already came out and told this to us. Otto Henrik Warburg, medical doctor, won Nobel Prize in physiology or medicine, I forget which one, in 1931, described the fundamental, pay attention, the fundamental difference between normal cells and cancer cells. And what he described is cancer cells cannot use oxygen to produce energy, anaerobic. Cancer cells form as a result of low oxygen environment. That's a major thing to keep in mind. So the origin of cancer cells from Otto Warburg's approach is that the cancer cells arise from damage to cellular respiration. Energy is through the fermentation, gradually compensating for insufficient respiration. Cancer cells continue to ferment and lactate. In fact, a lot of cancer patients, lactic acidosis or lactate is one of the byproducts that we look at. And this has a lot to do with oxygenation. And enhanced fermentation is the signature metabolic malady of all cancer cells. These are big claims that they're making here. So again, what is the fundamental difference between cancer cells and normal cells? Well, what do we know? We know that energy of most of the biochemical reactions in the body come from ATP. Normal cells produce energy primarily by using oxygen. This process occurs in the mitochondria. Cancer cells produce energy ATP largely by glycolysis and sugars, the metabolism of sugar without using oxygen, even if oxygen is present. And then the metabolic variation is the main difference of unrestrained growth and invasiveness are secondary to this difference. So sugar and anaerobic environments which has a lot to do with the pH, by the way, are very possible, something to keep in mind. Again, oxidative metabolism needs less glucose, the Krebs cycle, electron transfer, the production of the ATP, 38 molecules from one of glucose. Anaerobic metabolism or glycolysis produces 2 molecules from one of glucose. So much of the energy, for cancer cells comes from anaerobic metabolism. Again, due to damaged mitochondria, not necessarily the genetic DNA. So cancer cells need 15 times to 19 times more glucose than normal cells to produce the same amount of energy from one sugar molecule. Hence, the need for sugar by cancer cells. If the PET or the PET scan, where we give sugar to find out where the cancer is, didn't ring a bell, and cancers, wherever the sugar goes in that PET scan, we know that's where the cancer is. So this slide is hopefully reinforcing that excessive sugar drives cancer growth. Cancer also develop in a low oxygen therapy. So not only are cancer cells characterized by being unable to utilize oxygen because of damaged mitochondria, remember that I've given you many times that image of what a mitochondria looks like when it's damaged, when it releases the reactive oxygen species, when it's oxidative stress, and so on and so forth. But they also develop as an adaptation to low oxygen environment. So oxygenation is a good thing, necessary for patients, and this adaptation develops over a long period of time, becomes irreversible, like I've said in previous slides. So what causes a low oxygen environment in our body is due to a significant debate, but we live in an ocean of synthetic chemicals from our air, our water, our food, that will end up your makeup, your furniture, buying a new home. Drugs that were synthetic drugs will damage the mitochondria and the cell membranes, and this is what results in low oxygen to the cells. And it's in this environment that cancer grows. And I give you here the EWG website. If you guys have not visited the EWG.org website, I highly would suggest you grab your iPhone, your computer, go to the website up at the top right there. It says the EWG. Enroll in it, sign up for notifications. It is one of the best websites out there for consumer guides. If you have children, wouldn't you want to know what fruits are more at risk, what meat is more at risk, what makeup is more at risk? These people spend an enormous amount of time, energy, and effort and money to do research to provide you in a very simple, you can print out which fish is mostly at risk for certain conditions. What meat do we need to watch out for? What fruit do we need to buy organic? What fruit do we not? You can print out these consumer guides. So support these people if you can. It's a tremendous website. It has healthcare professionals, or even for your own health, this is a great website to know. Nutrient deficiencies, polluted air, harmful electromagnetic frequencies can affect the body in many ways, and synthetic medications, synthetic nutrient supplements, synthetic vitamins, for God's sake, right? You don't want to consume. Remember the difference between ergocalciferol and cholecalciferol? One is vitamin D2, one is vitamin D3. Well, if you go to your doctor and they give you a prescription and it says 50,000 once a week, that, my friend, is synthetic. That's D2. That's not D3. So get it over the counter, get it through Amazon, go to a store, get D3 with K2, because that's the vitamin D that's going to help you. And we know that with vitamin D, there tends to be higher risks for a lot of problems, including cancer. Calorie restriction, Thomas Seyfried, with his metabolic approach to cancer, has come to discover that caloric restriction has great results with not only in mice, but in humans to enhance mitochondrial health, which helps to maintain minerals and nutrients. It's not starvation. It's a form of fasting, but not starvation. You're still maintaining minerals and proper nutrients, and yet your mitochondria can. I won't go into this, but there are biomarkers for calorie restriction, such as reduced blood glucose or some of the elevated blood ketones the hydroxybutyrate, acetate, or the acetone can tell us if you're moving into caloric restriction or not. The keto diet, for example, hasn't been proven beneficial for all cancer, but some cancers benefit greatly. Even some diabetic patients benefit greatly, so they up their fats. Again, not the bad fats, the trans fats, but the good fats. But again, I would suggest that genetically one to do that test to see how they process the fats before they get into saying fats are good for you. Anti-tumor effects of calorie restriction. There's quite a few studies out there that say that calorie restriction it can have an anti-tumor effect because it has an anti-angiogenic effect, it has an anti-inflammatory effect, and it has a pro-apoptotic, so it kills a lot of the cancer cells and helps the body eliminate them as well. So again, caloric restriction can play a major role. And I have like 2 slides more to go. So foods are biochemical. They are bioactive chemicals: lycopene, sulforaphanes, vitamin C, vitamin K, folate, antioxidants,